Dr. Benjamin Youdelman is a cardiac surgeon who specializes in endovascular and aortic surgery and performs all types of cardiac surgery. He is the co-director of the Maimonides Aortic Center in Brooklyn, New York. He established Aortic Bridge, a support group in New York City for patients with aortic disease. Dr. Youdelman completed his fellowship at the Hospital of the University of Pennsylvania in endovascular and aortic surgery. Please welcome Dr. Benjamin Youdelman.
Hi. I'm going to just turn the podium as opposed to everybody else. All right, can you guys hear me? Fantastic. Green button I hear for the last couple hours. No. There we go. So, New York City, it's quite an interesting place. You guys know there's a lot of parks, beautiful open spaces. You know, some people actually just want their own personal space, so what they do is they carve out just little spots where their kids can play, which is just a really lovely thing. I don't know if you guys are familiar with this. Was big in the 1920s. They were called baby cages. This is not a joke. This is real, and it really was there. Of course, pizza is number one. Anybody from Chicago, who I don't know if anybody who shall remain nameless thinks Chicago has the best pizza. But this is on the left, you have Giovanni. On the right, you got Salvatore, of course. And I went in there my first Valentine's Day in Brooklyn, and I walked in. I'd been in there maybe twice. And I said, Giovanni, I got trouble. It's Friday. It's Valentine's Day. What are we going to do? And he goes, I got just a thing. And they made me that Valentine's Day pizza. And I took a bunch of pictures, and then I made them a big, huge thing on the wall, which was really kind of cute, and they loved it. So Brooklyn is a huge city. It's the fourth largest city in the United States if you actually would do it by the numbers, but of course it's inside of a much larger city, 8.8 million people. And in the bigger city, there's, I think, let's say 60 hospitals. Brooklyn, there's only 10, but we are the only heart hospital, and we're the only hospital that does aortic surgery in Brooklyn. There used to be 2 heart surgery programs, and they have since folded. So we do kind of all the work there. Some of the people in the fringes, they go to other places, but it's a pretty crazy place. Aortic Center is a term that gets thrown around a lot, and the concept of an aortic center is just a full service location where you can go and get your aorta evaluated. We've heard talks from cardiologists, we've heard talks from surgeons, and the whole issue of the aorta, and what I believe everybody really wants, is a full-service boutique approach to their bodies as a whole. The problem is it's really hard to do in this healthcare age, and we're trying to figure out the best way to do that. But if we fix your body and your mind is left to sort of squander with the internet, God forbid, you are going to have a really lousy existence for the 20 to 40 years that you're waiting either to get surgery, or 20 to 40 years, hopefully, that you'll live after surgery, waiting for your next, horrible thing to happen. And so we have to do a much better job. So we're going to talk a little bit about what we're doing in New York, of all the crazy places to be doing a better job for something like this. And then we're going to talk a little bit about education and outreach associated with Aortic Hope. Karen Anderson, one of the most phenomenal human beings I've met in a long time, with the exception of my wife, which is please record that. And then we're going to talk about outreach and education associated with both Aortic Hope and ThinkAorta, which is now the largest international campaign to raise awareness on aortic disease. So if you look at the left side, you have a normal aorta, and on the right side, you have a very abnormal aorta. You have an aneurysm of the ascending aorta, an aneurysm of the arch. If there was a pointer on this, not associated with the green button, I would show you, but I think most people can see what looks funny. And these are often found incidentally. Incidentally meaning I went in because my toe hurts, and oh, by the way, I had chest pain 3 weeks ago, and you get a CAT scan, now you have an aorta, now you are freaking out for months on end, and you don't know what to do, and you're now seeing somebody like me who you never wanted to meet in the first place. And I don't blame you. I don't blame you. I respect that. So you repair the aorta like this. Anybody who's going to pass out or throw up, just put your hands over your eyes. Most of us do this sort of thing because these are interesting pictures. On the left side of the screen is an aortic aneurysm. Yes, it does look like that with all the blood vessels going through it. It does heal itself. Tears are not torn and then it's just destroyed. It's not like it's just sitting there, I mean, it's a live breathing structure. But we replace it with nylon. Nylon doesn't expand, but you can imagine that the junctions where the nylon touches the heart or the nylon touches the nylon are very dangerous little spots, and that's where a lot of these problems can occur postoperatively, which is why we follow you for life, which is why you're stressed out for life, okay? Just so everybody understands what the problem is. Aortic dissection, whole nother ballgame, okay? The critical thing here, and everybody watching in the far-off reaches of Minnesota, these are different things, okay? An aortic dissection is a tear. Everybody's heard me who's ever met me. A is in the ascending, B is in the B-sending, right? B is in the B-sending, and the reason B is in the B-sending is because you're never going to forget that. And the reason that they are separate is not because they're not dangerous, it's because of what we do as surgeons. Historically, A's were operated on immediately, B's were never operated on before they became a problem. That is not the case anymore. We're going to talk about that a little bit. So if you have a dissection, you get a CAT scan, you can see it looks different. You got this line down the middle, and everybody goes, oh my gosh. And the one dissection that this emergency department physician has seen in the last 3 or 4 years, and they go, oh my gosh, and now they've just upset your entire family, upset you, upset everybody under the sun, and it's a complete disaster. Why? Because they're upset, because they never see them either. And then they call me, and I come down very calm because I see them pretty much every week. In fact, I didn't tell you this, Karen, I got off the plane, turned my phone on, and it just blew up with 2 pictures of a CAT scan and aortic dissection that I had to then help mobilize people. The patient's doing great, by the way. So I'll give you the name so you can send one of those gift packages. Thanks so much. So when you have an aortic dissection immediately, you can have anything under the sun. This is an aortic root. This is a mechanical root replacement. You heard a little bit about that stuff. And this gets descended on sort of similar to that string art that we all did in 4th or 5th grade. We kind of put it all together. It's exactly the same as the string art, except it's a little more exciting than the little owls that we made on that board. You remember with a stick sticking out? Yeah, same concept though, generally speaking. But things get very complicated with aortic dissections, and sometimes instead of just having one nylon tube, you can have multiple nylon tubes. You don't have to take a picture. I can get you these slides later if you need it, okay? Just pay attention, right? They say some things are meant to be photographed, others not, So the idea that the branches that go to the brain and the arms need blood flow, and if there's an abnormality, you have to actually make sure that they get adequate blood flow, and that's a big problem. But your abdominal aorta can have an aneurysm. If there's a dissection in the belly, it's called a type B because it's in the B-sending. Yes, you got it. You guys are getting good at this. Branches in the aorta in the abdomen are very much different. They go to your intestines, they go to your kidneys, eventually they go to your legs. But we have some phenomenal new stuff on the horizon. We have fenestrated grafts and branch grafts where we can put in these grafts in the event of aneurysms and dissections in the belly and get into these little tiny branches, right? So everybody's all excited about the aortic valve. That's been out for 10 years commercially available. This thing has only been out for 2 years. Nobody even knows about some of this stuff. The idea being that as we go all the way down the aorta, we can really reconstruct a lot of it doing minimally invasive endovascular work. So am I out of a job? No way, because we have not really moved the needle on a lot of this stuff in 20 years, despite all these efforts. So we'll talk about that some. So somebody said pseudoaneurysm and they had a rupture. So this is a really interesting case I wanted to tell you about. So on the left, you see the blue, is it blue? I'm colorblind. Is it blue, purple, whatever, that arrow that's not yellow, shows a little blip on the aorta. That's a rupture. And the reason it's particularly interesting, does this come off? I'm gonna do the rock star thing here for a second. So the reason this is particularly interesting is that this very nice lady had this stent graft placed here about 9 months earlier. I'd been following her for a couple of years when she ruptured here. So she comes back in, oh, my chest hurts. Well, that's disappointing. So then she ruptured over there, and that's associated with this dot right there. So that's not a small problem. That is a rupture, spontaneous, in the ascending aorta. The ascending aorta rupture is not a dissection. It is worse. Sounds crazy, right? How could it possibly be worse? Well, the reason that it's worse is that when an aorta ruptures, there's got to be some other issue going on. And when that other issue is going on, you know that the aorta is going to be really, really, really diseased. And so I, in my moderately marginal artistic merit, came up with this plan because we had to take advantage of this particular lady who was constructed a little differently than the average bear. The blood flow to her right arm actually came off as the last branch all the way on the left side of her body traversed around behind her trachea and her esophagus and then went off to the right side. We took advantage of that, reconstructed everything, and then put in a stent graft in the ascending aorta, not common. The way we did this is, as you can see, is we took advantage of the one in the bottom left-hand corner, that circle, same circle up in the upper left-hand corner, reattached all the vessels across, and then put a stent in the ascending aorta. So where you see that arrow where the blip is right in the middle of that stent graft in the ascending. Now, this type of stuff is not done everywhere, and it's not done commonly, and sometimes, quite frankly, it's not successful. But these are the advances that we're making to try and keep everybody safe. Because if we can do this in a 76-year-old lady who, if she underwent open surgery, might have benefited from living in a nursing home for the rest of her life with a tracheostomy on a ventilator, maybe, and we're able to do this, and she was able to survive, then we can certainly handle all of you otherwise healthy people, right? Easy stuff. So let's go to talk about something a little less grotesque. The community that you guys have outlined in the last few number of talks is phenomenal. I mean, I sit here in awe, right? I do this as a surgeon, but you can imagine I go home and, you know, I have to deal with other things at home, like, you know, 2 80-pound dogs and completely crazy children and stuff like that. And you guys have to go home every minute of every day and think about this. And I know that. I really do know that. And Karen knows that I know that. Aortic Bridge was my first formal salvo into creating this organization that was going to support patients, and quickly followed up with Karen. And quite frankly, COVID has helped a number of things in our work, even though you would be like, well, that's crazy. But no, it actually has. And I'm going to go through a bunch of things. Our ability to capitalize on the fact that COVID just kicked everybody in various parts of their body, depending on, you know, what you have. Thank you for getting that joke. I appreciate that. You know, you appreciate it. One person in the crowd. It gets you to the next joke, right? It just needs one. We had patients who were suffering from nothing, who were just fearful at home that they were going to die of a disease they'd never heard of, from a place that they've never heard of, that was affecting body parts that they barely even knew. And on top of that, we had all of you who had real diseases that they were concerned about. What we did during all this period of time is we really worked very hard to integrate everything formally. We always had psychiatry see all of our patients who were getting a heart transplant, who were getting an assist device, because really, you walk up to a patient and you say, hi, your body can no longer survive without this mechanical thing. Would you like to talk to somebody? Versus, you guys have the, hi, your body's about to blow up. Would you like to talk to somebody? I mean, it's kind of a crazy concept, but no one ever had psychiatrists see patients who had the type A dissection, let alone all the other diagnoses. And we've formalized that. Every patient with aortic disease sees a psychiatrist. The psychiatrist shows up to our support group meetings. She doesn't do a great job of coming to our combined support group meetings at night, but she used to come because there was food when it was in the hospital, you know. But anyway, she's very nice and she's very helpful, and she runs the consult liaison psychiatry service at the hospital. So all of you who are going to go back to your hospital and ask, you say, we would like to integrate the consult liaison service of psychiatry into the aortic program. And that's fundamentally what you need. So what we did with the help of Karen Anderson is we created a survey that combined the PTSD evaluation with a couple of questions about COVID, because everything was COVID for the last 2 years. And we sent it out into the world, and maybe some of you or many of you have answered this survey. And this survey was fundamentally designed to answer a very simple question. Not did you guys have post-traumatic stress disorder, but how bad is it really? Because we know seeing patients who can no longer function and perform the activities of daily living after having a type A dissection with a totally intact functional body is not because they physically can't do it. It's because your brain is getting in the way. And our study, which is going to be presented, this is the first presentation at an aortic meeting. It's been presented at a psychiatry meeting where all the psychiatrists are all excited to talk about things that they talk about all the time. This was accepted for publication at the American Association for Thoracic Surgery Aortic Symposium in Boston in May. And if you think that that's a small issue, I will tell you that is massive. To have other surgeons care, to use a nice, general, non-threatening word, care about this topic is awesome. And to see them care about this topic is really fantastic. And the reason that they care is not a small part of all the work that you guys have done here and that Karen's done and the tiny little microscopic amount that I've done when I wasn't doing my other thing. What did we find? Well, on the backdrop of known 5 to 10% post-traumatic stress disorder in the United States, with a known event of at least 5 to 20% of anybody who had standard heart surgery, we found that people with type A dissection were almost 50% occurrence, 50%. 1 out of 2 people had a dramatic psychological effect of this condition that made them unable to function in their daily life for a small or large period of time. That is unbelievable, okay? That is an unbelievable number. And if you asked anybody like me who does this for a living, they would say, oh, I believe that. And what have they done about it? Nothing. So our purpose for doing this is to show everybody that this is a real problem and to integrate psychiatry into this. But if you look at the other stuff, and I don't remember who said it, oh yeah, you have this condition, but don't worry about it, go home and don't think about it. So the watch and wait group, right? 12%. 12%. So you may say, well, that's not very high. The day before you got told to watch and wait, it was 0. And then in one day, it's 12%. That's massive. It's a massive difference in your life. That every single 6 or 12 months, you have to go up and down and up and down. And 12% is probably the average. It's not the up, right? And it's not the down. So what are we all doing here? We are trying to do that preactive strike to the world and say, if you become educated about aortic disease from soup to nuts, then you can probably do a hell of a lot better job of taking care of these patients than we've been taking care of. And I promised you that I speak from the literature in cardiac surgery, the literature in medicine, and the literature in psychiatry, that we've been doing a crappy job of taking care of all of you in order to have you get back to healthy and productive lives. Do we fix your aorta? I think I do a pretty decent job of that. Do we fix your valves? They have really good valves. That's great. But that doesn't help you. That doesn't help you when, I don't know, the percentage of people that cannot go back to their jobs, the percentage of people that feel like they are totally incapacitated, that they need to go on lifelong disability, that they are totally messed up with this fact because nobody came to them right off the bat and said, here's 20 people who just had this diagnosis. You're going to be fine. Okay, let's talk to them. Okay, now you're going to go into surgery. You're going to come in. You're going to be fine. Okay, now you're going to talk to them again. And then we're going to send you a nice little care package. And you're going to come to these support group meetings every month. And then you're going to come to a big cool thing. We're going to talk about it in a room. And then we're going to go to a rock concert. It's going to be really awesome. Now, that's the way to do it, right? If that's the way it was done for all of you, I promise you that your stress level would be way down about this diagnosis than what happened to all of you. We did not do this by ourselves, and we did not sit there. I wrote letters, and a bunch of other people wrote letters to all of the governing bodies, the American College of Emergency Physicians, the Society of Thoracic Surgeons, and the Society of Vascular Surgeons, and a couple of the 2 Eastern groups, because we're in the East. And they all signed on to ThinkAorta in order to spread the word, because they know, hey, this is big. This is a big and important thing. Distribution of material, raise awareness, and increase the knowledge about how common aortic disease is and its inheritance patterns. And you're going to see ThinkAorta, ThinkFamily a million times on the internet, and you're going to see it a million times from me and Karen and a bunch of other people. But let's talk about what that really is. Inherited diseases are many, many, many. And I don't want you to think that there's just these 5. But let's just talk about the ones you know. Everybody goes to the doctor. Heart attack, stroke, diabetes? Yes or no? Heart attack, stroke, diabetes? Yes or no? If you say somebody died of cancer, they'll go, ooh, cancer. And I stand up here before you, the lucky recipient of BRCA2, which you may say, oh, that's the breast cancer gene. Well, I don't have breasts, but I do have a pancreas, a prostate, and what else do I have? I have something else. Oh, and a GI tract, all of which get affected by that because it's not a breast cancer gene. It's a cancer gene, okay, everybody? Cancer genes. There's vascular genes and there's cancer genes. And we can all split hairs about which part and where you're going to go and your problem. Does anybody want a cancer gene? Anybody want a vascular gene? No, you don't want any of these things. But they all come down as gifts from your parents. You don't just get those nice, the copper colander from grandma and the nice dish set and the silverware that you never use because every time you use it you have to hand wash it and it's a total pain in the ass. You also get genes, and this is the big deal. And if you look at these numbers, and it's easier to do it in terms of deaths, and I'll tell you why. Because these are the real numbers that are on death certificates, right? And then what about aortic disease? Well, at least 10% of the population has aneurysms. And how do I know this? I'm going to tell you in a second. But here's what I wanted you to know. There are 20 genes and counting. 20 genes and counting. Some of the genes are shifting to the left, and some of the genes shifted to the right. To the left are the really, really, really unfortunate souls. Those are the people who are walking around with normal-sized aorta and have a dissection. And they come in, and you operate on them, and you ask them, where's your mom? She died of a dissection. Where's your dad? He died of a dissection. Where's your grandparents? They died of dissections. Okay, did anybody tell you this is inherited? No. Really, 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 really bad. Somebody asked me, what do you define as an old surgeon? An old surgeon is a surgeon that doesn't know about this. A young surgeon, young, handsome, and somewhat tall, although balding, with a personality that defies my hairline. That's what a young surgeon is. Somebody who knows that when you teach somebody, patients and residents and medical students alike, you must explain to them that everything is inherited, and we have no idea to what degree. In 1999, the human genome was sequenced. 1999, that's 22 and a half years ago. We know nothing about the human genome. We know a lot about those little fruit flies, the Drosophila melanogaster, because we had that sequence like 50 years ago. We don't know anything about the human genome. We think we do. So all the genetics that you see are just scratching the surface. So if you have it in your family history, you have a great chance of getting it. That's all we're going to say about this over and over and over and over and over again until everybody learns it and does something about it. We took advantage of COVID. Another positive about COVID, there weren't that many, but here's one. Definite disadvantage was me having to breathe my own breath all day long, especially for a long operation without having to brush my teeth 15 times a day. I was the last man standing after two of my colleagues got COVID. One guy went out for another health problem. Another guy worked at a different hospital. And for 2.5 months, I was the only heart surgeon at my hospital. But there was no surgery because everybody was at home dying from various conditions, not just COVID, because they were afraid to come to the hospital. But the ones that did, they got a CAT scan because that's all we had. So they were getting a CAT scan as a diagnosis for COVID. So I was sitting there day after day, bleary-eyed with coffee, bored out of my skull, reviewing 1,500 CAT scans. And what I found was unbelievable to everybody who I work with. And it's unbelievable to all of you. And it's been unbelievable to everybody I've told about this, which is that I found an incidence of aortas that were greater than 4 centimeters in a population that spans 90 plus different countries in Brooklyn. I don't know if any of you have been to Brooklyn, but there's a lot of different people there. This is not Minnesota, you know what I'm saying? Not that you guys have only one people here, but Brooklyn is a little different. Almost 15% of the population has an aortic aneurysm greater than 4 centimeters. And if you go to 4.5 centimeters, which you saw a lot of people put up there, it's because 4.5 is a real aneurysm. 5% of the population. 5% of the population of Brooklyn, which is almost 3 million people. You think we're seeing that many people? No chance. They're not coming in. But they come in when they have a problem, and then it's picked up incidentally, and that's the problem. That's the fundamental problem. The other side of the story is that 30% of patients with aortic dissection on the left side of that screen, they also get dissections, and they don't even have an aneurysm. So all the people that we pick up, we still got a bunch of people that get it, and they don't even have anything that you're going to be able to physically see or listen to know that they're going to have a problem. So what do you know? What happened to your mom? Oh, she died of a massive heart attack. How about your dad? Yeah, same. Excuse me? On and on and on and on. We have to change this paradigm. That's what we're doing here at these types of events. We're changing people's brains to understand what's really going on. All we have
is to ask about family history. And all we have is to image these patients. And if you're adopted, somebody in this room is adopted. If you're adopted and you don't have any of that history and you don't have an aneurysm, I can't tell you that you're not going to have a dissection. So I don't want anybody who's not had an aortic problem to like now leave in this watch and wait fear that something bad's going to happen to them. But pay attention to the family history far more than you did before. And tell everybody, not for fear that something terrible is going to happen to you, but so that you can go to your doctor, now that you have a doctor, thank you, and you can get evaluated and you can get identified early and things can be done. You have to think aorta, think family, you have to think cancer, heart disease, stroke, diabetes. It's all the same. We are now in 8 countries, and I say we because I've been involved for, 2 years now, I think? 8 countries, but there's more coming. There are countries where this will not work. This may not work in the United States, but we're going to do our very best, and we're all going to do this together. So what about paramedics? I already saw there was no show of hands that anybody's a paramedic. So paramedics are awesome people. They get, varying training depending on how much they want to do. And they go into people's houses to pick up somebody who's not feeling well, and they ask these 6 questions. Signs, symptoms, allergies, medications, past pertinent medical history, as opposed to the past useless medical history, which we all, your last oral intake, your last menstrual period, and so what happened? Events that happened. But they don't ask anything about family history. So let me go through that. These people, they walk into the house where the whole family is standing over you. They ask all these questions. They don't ask anything about the family history. Then they leave and take you to a hospital 20 miles away. You don't get there because the family, they've got to go to, the men have to go to work, right? The women then have to go to work and stay home. Then one daughter, usually, thank God I have 2, goes to the bedside and they say, any family history? Daughter, I have no idea. But they didn't ask when they were standing there with the entire family. So we went to all of the paramedic training people and asked them to put this in their training. And they said, oh, yeah, well, it's not really pertinent for us. It's not that important. They just redid the entire EMS training curriculum. And when I sent emails to every single member of the board and asked them to include it, they said, well, we already have something like that. It's not necessary. It's not that important. It's very, very hard to get people to understand. But here's some crazy, crazy, crazy facts. In 2004, the U.S. Surgeon General, 2004 is almost 20 years ago, thought that this was so important that they created this whole website, which nobody in this room except me has ever seen. I don't even think I told Karen about it, but there's no way she looked it up. Because there's no reason to look it up. But you can input all of your family medical history and all the nuances and stuff in order to have everybody know in government what's gone on with your family's medical history. You sensing a problem here? Everybody sensing a problem? Yeah, this was doomed for failure from Jump Street. But they did it. But they did it because they knew it was important, but nobody followed up on it. And when I met with a very nice gentleman named Fleetwood Lustelat, I know it's a mouthful, but that's what his name is, and his 5 colleagues who head up the CDC Heart and Vascular division, and I met up with him, I think it was the 23rd of January 2020. You guys following me? January 23rd, 2020. Had a very nice meeting with him. He was ecstatic about this. He was so excited about this. He thought it was awesome. He has been distracted for 2 years and has no interest in receiving any emails from me anymore. But at the time, prior to the other shoe dropping about COVID, 1 week after I met with him, he was pretty interested. And why was he interested? He was interested because of facts like this, which is if you sift through the literature, and I have a bunch of them, but this one is ridiculous because I promise you that I didn't know this after going through just a little bit of medical training, and I promise that nobody in this room knows that either. It is unbelievable that if you have an appendicitis, that other people in your family probably had an appendicitis. Now, if you think about it, it makes sense. The appendix is this thing that's sticking off of your intestines, and if yours is prone to block, then maybe your parents is prone to block, and maybe your grandparents was prone. It all makes sense if you think about it, but there's no way that they taught me this in medical school and that anybody knows this. So how could you possibly help with this situation? Appendicitis is one of the most difficult diagnoses. Yes, CAT scan is helpful, but it's a really tough diagnosis. And if the paramedics went into the room in the house and ask the whole family, has anybody else had appendicitis? Everybody raises their hand. Well, then they can go in and tell the doctor. What do you think the emergency room doctor would say if a paramedic said, the whole family's had appendicitis? He'd be like, that's nice, I'll take it from here. Because people don't even know about this stuff. We have to change the paradigm of aortic disease and learning about aortic disease in this entire country and in this entire world in order to save the lives of all the people that you guys have heard of and to make you guys have elective surgery as opposed to the emergency surgeries that you've had. Calcium scoring CTs are being offered from most unions and most large groups. So if you work in a big company with greater than 500,000 people, they're offering it so that the insurance company can know and get you diagnosed and treated and put on the right medicine so that the insurance companies don't have to deal with you getting an operation because it's really expensive. Let that sink in. Lung cancer screening is done for everybody who smoked so much that they probably have cancer. Okay, that's brilliant. But there's no CT scan for someone who's got a family history of aortic disease. What do you think is the actionable data associated with those top two? You think it's more than the third? I don't know, because there's no data. But I will tell you that if you took someone at 50 years old and you did a scan and looked for lung cancer and looked for calcium and you looked for an aortic aneurysm, you're probably going to find something. And they'll probably be able to help them change their medicine, maybe even save their life. How is that going to happen? Probably 50 years from now, maybe longer. But all of these things dovetail into early diagnosis and treatment, which we're all working towards. We all joked when we were in medical school in the 90s that when we turn 50, which I already have, we're going to get a head-to-toe CT scan. We're going to find all this disease. They're going to pluck all these tumors out of us. And then all the data started that people are having a bunch of incidental unnecessary surgeries and dealing with all the complications and that the numbers don't add up. And I was like, oh, that's disappointing. I thought that was going to work. Then I find out I have this other problem, and then I was like, oh, that's not going to work. Every year, I get 2 MRIs. Every year, I get an endoscopy. Every year, yes, I get a mammogram. Hugging that machine is weird, I got to tell you. It's a very awkward. Only the women know what I'm talking about. Trust me, it's pretty weird. It's pretty funny. I have pictures. No, I'm not going to show them to you. But if you have a patient and there's no history of aortic disease and they all live to their 90s, does that mean they don't have an aortic aneurysm potential problem and that their hypertension shouldn't be controlled? No. It just means their families didn't rupture. Great. Good for them. But if you have an 8-centimeter aneurysm, I'm going to operate on it. That's it. End of story. And if you're, adopted, like we talked about, it's a bummer. I want you guys to read this. Should I read it for the people in the far corners of Minnesota, or can they see it? They can see it? Oh, good. Okay. So read it at home, please. Thank you. It's so obvious to me that if you look back at your family history, if you have it available to you, and if you look forward to speak to your siblings and your children and their children about all the diseases in your family, and don't freak out about it. Just talk about it basically, about it's facts. These are facts. Then they can protect themselves. I don't care what it is. Our objective is not just to save everybody from aortic disease and let them all die of heart disease, stroke, diabetes, and cancer. No, our objective is to have everybody think about this in a better way. The reason that this campaign works is because it gets everybody paying attention to what actually matters. And why does it matter? This is why it matters. You guys may have heard about these walks that we do, which are now, we're all in this together, right? Karen and me and all of you, we're all in this together. You guys want to fly to New York and come and walk across the Brooklyn Bridge? It's one of the most absolutely spectacular bridges in the world. Obviously, the view is pretty good. Yes, I pay for food afterwards, so that's also good. This year, we had a total of about 110 people. 90 of us walked across the bridge. 20 of us just met us at the bar. I can't do anything about it. Listen, what am I going to do? But every year, we have this walk, and what we hear from everybody, and these are not just patients and families, these are my team too, my team. We all work together because we're all trying to deliver a different type of healthcare. And I'm not the only one. There are a lot of really great people out there trying to do the same stuff. And all of you know physicians that do this stuff. We all just have to do this together. Thank you very much for having me here and for doing this and for allowing us all to do this together, because there's no question that doing this all together, we're going to be way more successful than doing it by ourselves. Thanks a lot.